The most expensive enrollees, people with disabilities, people in nursing homes, people with expensive chronic illnesses at greatest risk.
We're talking about cutting $10 to $20 billion out of our state budget to maintain our 15 million people on Medi-Cal. We just can't do it.
A lot of the cuts that we are talking about would certainly increase costs in the near term and to all of us in the long term, period.
Welcome to The Other 80. I'm Claudia Williams. Congress just passed a commitment to cut $880 billion. And we all know that can only come from Medicaid. It's been on my mind, and frankly, on the minds of my students too, at the Berkeley School of Public Health where I work. They have questions, and so do I. And so today, something new. I have planned to save this for our 50th episode, which is coming up, but it's too timely to wait. I asked three of the smartest people I know to talk about the impact of the election on Medicaid. Past guest Kody Kinsley, former North Carolina Health Secretary, and Larry Levitt, EVP for Health Policy at KFF. Plus, the other 80 newcomer, Kody Heidorn, California Healthcare Foundation's Director of State Health Policy. If you find this conversation valuable, please leave us a review on the Apple Podcast app or subscribe to The Other 80 wherever you listen. And if you'd rather watch the video of this discussion, click the link in the notes for The Other 80 YouTube channel. Remember to click subscribe and hit that notification bell for updates on the new video episodes and extras from our regular episodes. So whether this is cathartic or immensely depressing, here are the goods from my three friends. Please welcome Kody Kinsley, Larry Levitt, and Kody Heidorn to The Other 80. We're really, really excited to have three panelists here today to help us navigate this both challenging and ever-changing question of what the impact of the election is going to be on Medicaid. I would love to have each of you introduce yourself, both who you are, what your background is, but also what particular perspective you bring to this question of Medicaid at the current time. Starting with Kody.
So I'm Kody Heidorn. I'm the Director of State Health Policy at the California Healthcare Foundation. I've been at the foundation for about 2.5 years. So I work in philanthropy. Our foundation makes about $40 million in grants mostly to researchers and to some nonprofits. And we publish a lot of data and a lot of research really focused on low-income Californians and getting them health coverage, making that health coverage affordable, making it equitable, and a variety of other topics. So a lot of expertise in both our state legislature making laws and then in our executive branch implementing those laws. And then I left for my next chapter in my career. I worked at a couple nonprofits, and then I also was a lobbyist for a health plan called HealthNet. So got a taste of for-profit health plan focused on Medicaid across the country, which was a really, really interesting experience as well. So happy to take part in this conversation today.
Hi, everyone. It's great to be here. My name is Kody Kinsley. I'm an operator with a policy problem and good friend of Claudia and proud Berkeley MPP grad. So great to be here. Most recently just wrapped up my tenure as the Secretary of Health and Human Services for the state of North Carolina, where we expanded Medicaid, forgave $4 billion in medical debt by leveraging state-directed payments, a key part of the Medicaid program. Had our very successful Healthy Opportunity pilots where we were saving $85 per member per month by investing in food and transportation and other health-related social needs, and made some significant changes to how our Medicaid program works to support mental health and behavioral health broadly, which is a very bipartisan issue. And so I come to this conversation having been for the last 7 years of the department, 3 years as secretary, in a very much a building phase, having a lot of final bipartisan breakthroughs in the General Assembly, and now seeing, I think, nationally a posture where I'm worried that we'll see the baby thrown out with the bathwater at Medicaid, and looking forward to this conversation.
Great, thanks, Claudia. I am a Cal grad. Got my start in state government in Massachusetts. Spent time in the federal government and also in California state government. And I'm currently the executive vice president for health policy at KFF, where I oversee all of our work on Medicaid specifically, but also Medicare, global health, racial equity, women's health, the Affordable Care Act, consumer protection. And for those of you not familiar with KFF, we're a health policy organization, a nonprofit. We do policy research, polling, and journalism. Our aim is to just inform big debates like we're about to have this year on Medicaid.
Before we jump into what might change, I thought it would be good to lay the tracks for what Medicaid looks like, who its constituents are, and who it serves in the two of the states represented on this call. So we'll start with Kody, and then we'll go to Katie. Kody to talk about North Carolina, Katie to talk about California, and really just give us the story, the vignettes and story about Medicaid in those respective states. So Kody, starting with you.
Sure thing. So as I mentioned in my introduction, North Carolina recently expanded Medicaid, and in our first year of having Medicaid expansion in place, we put 617,000 individuals onto the Medicaid program as part of that. Now, taking the Medicaid program in North Carolina roughly to 3 million people, about 30% of the state's population. Folks may know that of the expansion population in particular, 80% of those individuals are working. We think about our childcare workers, our farmers, our people who are integral to our economy and key to a functioning state, now having health insurance for the first time in their lives. We still have probably about 500,000 people in North Carolina that don't have health insurance of our 10.6 million, but we were able to cut that gap in half with the Medicaid expansion program.
So our Medicaid program, we're about 15 million people in Medicaid in California, but similar to North Carolina, about a third of our population. So proportionally, very similar statistics. About 80% of those folks work or in working families. We expanded Medicaid way back in 2014. We have I think over 5 million people were part of that expansion population. We're in the middle of a pretty amazing Medi-Cal transformation program that we call Cal-AIM, and we're really trying to connect healthcare to community supports and to our communities to really focus on the whole person. So all of their needs, not just their medical needs, but really focusing on, do they need housing? Do they need meals to help them be healthier? We're really trying to push our Medi-Cal program way beyond the bounds of just healthcare and way into our community. And we're right in the middle of it. We're about 3 years in it, and we've got 2 more years of our program. So wish us luck.
Larry and I had a conversation just before the election, and I would say one of the conclusions of that conversation was that healthcare had not had a big role to play in the election debates and discussions. And I think we left that discussion saying that doesn't necessarily mean that things won't shift, which we'll get into in a minute. But Larry, if you could give us a flavor of how healthcare in general, ACA, Medicaid, what kinds of discussions were there during the election about these issues?
Yeah, I mean, this was such a different campaign when it comes to healthcare than we've seen in really decades, in a sense. I mean, so many campaigns in the past have been centered on the prospect of health reform, the prospect of repealing healthcare reform. Healthcare barely got mentioned in this election. I mean, there were times when it started to come up, and it just was not a central issue, and that's very unusual. But as you said, the important thing to think about elections is an issue like healthcare may or may not come up in the campaign. That does not mean that the election doesn't matter for healthcare. I mean, elections almost always have consequences for healthcare.
One of the things that I think has become very clear is that this administration is very, very focused on reducing the federal workforce and reducing the budget. There are not too many places to go look for big budget cuts that are not things like Medicare and Social Security, which so far people have said are off limits. So let's start with the executive branch. If the executive branch were looking to cut Medicaid, which I think is very clearly on the table, if it was looking to limit Medicaid, if it was looking to shape it in a different way, what could it do without any legislative help?
Traditionally, the biggest lever an administration has had through executive action over Medicaid is through waivers. These are waivers that they grant to states to kind of change the contours of the Medicaid program that's set in statute. And sometimes these are kind of bottom up from the states, where states have ideas, they present them to the federal government. Sometimes they're top down in the sense that an administration says these are the kinds of waivers we're looking for, that we would invite, that we would approve. These are the kinds of waivers we would not approve. And the direction changes a lot from administration to administration. So, for example, the Biden administration placed a very big emphasis on equity, on racial equity, and approved waivers to do that. Also placed a big emphasis on addressing social determinants of health, things like housing and food security. And Kody and Katie can certainly talk a lot about what California and North Carolina have done. The Trump administration is certainly not going to emphasize those things. So I think we'll see things like work requirements, either administratively or through Congress, things like capping Medicaid spending, sort of a voluntary cap that a state might agree to. And Tennessee looked at a proposal like that in the first Trump administration. Things like restricting enrollment by making it harder for people to enroll, making them renew their Medicaid coverage more often, making them jump through more hoops with income verification, and indirectly through changes in immigration. The more you restrict immigration, the more you put fear in the minds of immigrants. Immigrants who are here lawfully, who are eligible for Medicaid, are going to be hesitant to sign up.
One thing I like to point out in this context always is that North Carolina's 1115 waiver that had its first demonstration of what we call healthy opportunities, our pilots, was initially approved under Seema Verma and the Trump administration in his first term, and so I'm a little curious about we have a health secretary in RFK purportedly focused on healthy food and prevention, and I think the question will be, will North Carolina's pilots have evidence they're working, they're lowering costs, they're moving towards primary prevention. This is a great strategy, and frankly, it was put in place under a supermajority of Republicans in North Carolina who are trying to lower costs for Medicaid. Will that take hold, and how will they square that in the context of the broader thing? So I think that's the only thing I would add at this moment, but I think we're still obviously questioning a lot about what will happen.
Kody, it's so interesting to hear you talk about North Carolina, because our political climate in California is just so different. And California is just, as you all know, symbolically in a different place than most other states. I'm in the process of pulling together a presentation for our board members in the next couple of weeks, because they're like, what's our federal strategy? And when you look at how our governor has responded and how our attorney general has responded, our governor is really walking a line and saying, if there are places we can agree, we're going to work with the Trump administration. And our attorney general has already sued the Trump administration 5 times. We can go down a rabbit hole and try and line up all of our things and say, well, this one might work and this one might not, and they might approve this. But I think what Larry said for us in California is so much more important. They're using levers that we didn't know existed. And so I think, for us in California, if you just touch Medicaid, that equals billions of federal dollars for us. We get 1/3 of our funds from the federal government, and most of those are from Medicaid. So if you touch work requirements, that impacts coverage. If we do per capita cap, California loses billions of dollars, and that blows up our whole state budget. So we're almost not looking at the individual policies at this point. We're really waiting to see what makes it on paper, and how we can respond to those very specific proposals. Otherwise, we're looking at, we're sort of staring down this massive budget problem in our state.
Obviously, there have been a lot of news articles about the federal employees that have both left through the voluntary effort and have also been let go over the last week. And I think there's a common perception that the federal employee workforce has grown astronomically, which is not the case. And in fact, it's at levels that are been basically the same for more than 50 years, have gone up and down a little bit. And that dates to before even Medicaid and Medicare existed. And so one of the things, and I was part of the review team for 1115s when I was at ASPE. So I know how long those processes can take. And imagine trying to do that with way fewer staff or with great uncertainty and concern. So maybe just pause for a minute on this question of how will the federal workforce affect some of these questions, even apart from the policy direction itself?
I'm going to go back to my Assistant Secretary of the Treasury hat and say, we have seen this play out with regard to the Internal Revenue Service for decades, which is, when you starve an organization that then, leaves billions of dollars of uncollected taxes and customer service experiences that are really hard, that reinforces a narrative of the government being a poor performer, then it becomes a little bit of a self-licking ice cream cone. And what I worry about is there will be I think in the grand scheme of things, there will be the loss of certain services, things provided, processes completed, whether it's the VA or CMS or whatever. But I think the biggest loss here is continued erosion of confidence in government to do what its primary purpose is, which is deliver services for people.
Yeah, I would say too, this will have very lasting impacts. It's very easy to tear things down in government. It is very hard to build things up in government. And the amount of expertise we're losing through people leaving, through people being fired, and, frankly, discouraging young people from going into government right now. It's going to take a long time to build back up that expertise and build back up these institutions.
Just on this question, I know we have a lot of students, mostly MPH students on the line, some of whom were actively looking at federal opportunities. What advice would you give them right now?
If I were in that position, I think I would be very hesitant to take a job with the federal government right now. Aside from the question of, whether the values of the current administration match your values, I think it's just going to be a very unstable, difficult place to work right now, which is unfortunate.
Yeah, I can tell you, working for 10 years in the public sector, for most 10 years in the federal government, is incredibly rewarding. It is the hardest working people I've ever worked with. It is the most complex problems you get to solve, and the gratification of getting to do that, to have positive impact on people, is rewarding. So maybe now's the moment to go work for a state government or a local government to lean into their lovely federalism, but keep federal government on your radar. As Larry said, they're going to need you to build back better later.
I totally agree. And I know Marco Meach, who's one of our close colleagues here in California, just posted a wonderful post, I think over the weekend, saying, come work in California, come land here. And there's a lot of amazing opportunities, not just at the state level, but also at the local level to do incredible work.
And Claudia, just if I could, there's industry and there are other places to go. So if you're, I'd almost be a little concerned about, I agree, absolutely go work for state government. But also, there are other places you can work besides government as well. And any experience in your field is experience. Don't limit yourself to government. There are many, many opportunities out there.
Before we move on to some of these big changes being discussed in DC, I just want to double click on this question of waivers. So North Carolina has major waivers that will be up over the next several years. So does California. 1115 waivers primarily, but also different kinds. without being able to know the future exactly, what has been the past tradition or history around whether waivers get pulled back in a new administration? So, in other words, could the claim waiver get pulled back right now? And then also what track record is there in other administrations around approving waivers for a second round that might have been initially approved in a different political climate?
I mean, it is certainly in the authority of an administration to rescind waiver approval. It's extremely unusual. It has happened. In fact, the Biden administration did it or tried to do it in Georgia with a work requirement and a partial expansion of coverage, and was unsuccessful in the courts. But they do have that authority. I think it's very unlikely that will happen. I think that states, blue states in particular, that come up for renewal of their waivers will be put through the ringer. I would not be surprised to see, measures that try to punish those states. So, for example, California, not through a waiver, but separately using state-only funds, has expanded Medicaid coverage for undocumented immigrants. And I would certainly expect that to be a target of the Trump administration in any future waiver negotiations, or potentially even a target of Congress.
All right. So there are going to be proposals, whether from the executive branch or the Congress, to make major changes to Medicaid. I think that's undeniable. And we do have at least a set of potential proposals on the table for the budget reconciliation. So as part of this sort of parsing out what could happen, let's first talk about budget reconciliation. What is it? And why does it matter for this conversation? It sounds very dweeby.
I got my federal budget process book back here in the bookshelf. Pull out if you want. But sorry, Larry, you were going to give a much better answer. Go.
No, you should jump in. But the budget reconciliation has been used by both Democrats and Republicans, and it has certain key advantages and certain key disadvantages. The key advantage is that you can pass legislation that cannot be filibustered in the Senate, meaning that you don't have to get 60 votes to break a filibuster. You only need 51 votes, including the vice president, as a potential tiebreaker. And that's crucial because the Republicans do not have 60 votes in the Senate. The key disadvantage is that there are certain restrictions on what you can do through this budget reconciliation. The easiest way to think about it is that provisions have to affect the budget in a meaningful way, either increasing the budget deficit, decreasing the budget deficit, increasing taxes, decreasing taxes, increasing spending, decreasing spending. That you can't make policy changes that are incidental to the federal budget. Democrats used it most recently in the Biden administration to pass the Inflation Reduction Act, which required Medicare to negotiate drug prices, expanded premium assistance under the Affordable Care Act. Parts of the Affordable Care Act were actually passed through budget reconciliation as well. Republicans used it to enact massive tax cuts in the first Trump administration, tried to use it to repeal and replace the Affordable Care Act and cut Medicaid spending, but were unsuccessful in that. So it's an extremely powerful measure. But has some restrictions, and there are some procedures that come along with it that are extremely arcane that we will see play out over the next several months.
And at its most mechanical is it's bringing together the budget proposals from the Senate and the House, right, and reconciling them. So it's a way to come up with a common view of the budget, but it's often a vehicle for major policy change because of the attributes that Larry mentioned. It's much easier to pass, especially if you have a narrow majority. It's much easier to pass something in this budget reconciliation process. What I thought we could do is take some of the policy elements that may show up in reconciliation or may show up in other ways and talk about them a bit, both from the standpoint of what is this? What impact might it have? And we can again use North Carolina and California as examples, and kind of what is our political prognosis for this area. And let's start with, okay, so capping federal spending through block grants or per capita caps. So again, we're not saying that any one of these is likely to happen, but if you're looking for big savings, you have to make big moves. And so one of the big moves that's been proposed is some kind of cap on federal spending. And the block grants have been proposed in the past, but also we have this concept of a per capita cap. Does somebody want to jump in and talk about like what is this and what impact would it have?
So I think I will jump in starting from a political frame, which is I actually think this one has, I have been generally a little suspicious that we would see a shift in FMAP or in block granting for a variety of reasons that I'm sure we'll discuss. But I think this one is the more likely one because I think that there is an allusion towards and something kind of interesting to state lawmakers about the opportunity to have more flexibility. And that flexibility, even though, if you think hard about, the rising costs of healthcare, all the dynamics there, the amount of money that states, Katie beautifully outlined how much of California's budget is part of the federal match, right? If you freeze it today and you can't continue to grow later, then that's the state eating a lot of future cost. But, if you think about state legislators being elected every 2 years in North Carolina, the fact that it may not be their problem later then, but they get to be a part of this big thing. And I think the dynamics of state legislatures with the federal delegation members is really going to matter in this process. And so that's less of a what and more of a like my prognostication on why I think this one may actually have some chance of happening. But I do think that the brass tacks problem will be that, sure, states may garner a significant amount of flexibility in being able to manage their Medicaid program, but that is at a very high price just 1 or 2 years later as these programs continue to evolve.
I'm going to disagree a bit with Kody here that I think it's the least likely proposal to happen. So the idea here is, right now the federal government matches state spending. It's an entitlement, meaning however much a state spends, the federal government will match it at different rates in different groups and across states. A per capita cap is very appealing from a federal budgetary perspective because you put a cap on that and you cap it on a per enrollee basis. So there's less incentive for states to reduce the number of people they cover because then that reduces the amount of money they get from the federal government. If they increase the number of people they cover, it increases the amount of money they get, but it caps the growth in federal spending. But it introduces a really, really difficult political problem, which is what's known in Washington as a formula fight among states. So how much money should each state get? And states are starting from very different places. So you might kind of just naturally say, okay, we'll start, every state starts where they are, and we're just going to cap the growth in federal spending per capita, per enrollee in each state. Problem is, states that have been very generous in their Medicaid programs, providing a lot of benefits, paying doctors and hospitals and nursing homes a lot of money, they're at starting at a much higher place. States that are, paying less, covering less, start at a much lower place, and it locks in those inequities kind of forevermore. And then you start getting, the senators and members of Congress fighting, well, we want an adjustment for our state, adjust us up a little bit. And then you're into this just massive fight and negotiation to try and get every vote.
So interesting hearing both of you talk about this. And also, California is one of those very generously benefited states. And we obviously have the most people on Medi-Cal in the country. The states that have more generous benefits typically are the Democratic states and have, and the other states are not. So I think even that on top of that, Larry, just adds to the political pressure to push down the benefits in the Democratic states and lift up the Republican states, given the current administration.
And it's good to remember that, typically Medicaid is number 1 or number 2 in state budgets, right? And the tricky part for the administrations, for the governors, is that the levers they can control are not benefits, right? Because the benefits are really, to some degree, like you can decide not to do cool Kellyanne programs, but you can't really change the core benefits. So your only lever is enrollment, which you typically try to attack through indirect means or just by not expanding. So this would open up, as Kody said, a very intriguing set of other options, which would have to come with some flexibility on benefits. Like there's no way to do a per capita cap and not go back and say, you don't have to do all this stuff. And so it opens up a lot of questions around, could you have a more bare bones package? Could you not offer dental care? I mean, I don't know what those options would look like. So there's also debates and discussions that would have to happen at a state level. Who loses in that? Is it the safety net providers? Is it the people who need Medicaid coverage? Is it long-term care? So it opens up so many negotiations, not just around the dollar amounts, as Larry said, but also around actually who gets benefits, because you wouldn't be able to maintain the benefits necessarily.
It opens up discussions, but also some potentially unpleasant implications. So if you cap spending on a per enrollee basis, you can quickly do the math and realize, okay, if I get rid of some of these expensive enrollees, then it will be easier for me to meet that per enrollee cap. So it puts the most expensive enrollees, people with disabilities, people in nursing homes, people with expensive chronic illnesses at greatest risk in states that are looking to cut their spending and come within the cap.
I think we have to continue to remind everyone that compared to many other payers, if not all other payers, Medicaid is pretty much the only game in town when it comes to long-term care services and supports as folks age. And I think that the frame of, who is on Medicaid, a lot of people think young working families. And so that invites the conversation around like, you get to be on Medicaid for 2 years and then you're done and da, 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 da. But when you think about people with a disability, or as Larry said, someone who is aging, like, kicking grandma out of the nursing home, not a very politically viable conversation. And I think an important part of the kind of values conversation we need to have.
And that's good for everyone to remember that Medicaid is pretty much the only game in town, like you said, when it comes to long-term care, and spends about half the money that is spent on long-term care in the country. So we edged around this question of different ways to cut. And another way that's been proposed is to cut the FMAP. So the FMAP is the percentage of the costs that are borne by the federal government. Currently, that has a floor of 50%, and states like California are at the floor. And one of the proposals has been to release that floor and allow it to go down. It's wealthier states that have the lowest floor right now, which also tend to be Democrat. So if you were looking for a way to cut money that would affect Democratic states more, this would be a way to do it. Let's talk about that. What are the dynamics of that kind of a cut, and how might it play out?
In California, if we cut any part of the FMAP, we're talking billions of dollars, really $10 to $20 billion for our state. And that just to give you a sense, we have a balanced budget this year, and we've got a small surplus of $363 million. So when you say we have a small surplus of $363 million, and we're talking about cutting $10 to $20 billion out of our state budget to maintain our current, 15 million people on Medi-Cal, maintain coverage for undocumented immigrants, maintain all of the benefits that we have, maintain all of the great transformation programs. We just can't do it. And we've been through this before. So, a really good example in California is what happened during the Great Recession in 2008, 2009. We cut the budget in California from 2008 to 2012. So for 4 years. And it took years to add back 10% cuts in dental care for people. So this gets really, really painful, really, really fast. And California, we'd have to look under every possible couch cushion, not just in health, but probably in other places like education, climate, et cetera, to dig out of that kind of a hole. So this would be a very easy, if this could get through Congress, boom, billions of dollars out of our state budget, and really, really difficult conversations in our very progressive legislature. Nobody wants to make those types of cuts.
Let's talk about a couple more, and then we're going to step back and talk about the politics a little bit and the dynamics of the politics. Another proposed change that has been approved in some waivers in the past is work requirements. And there's been talk of making making it easier to get a work requirement put into a waiver, but also even talks about requiring work requirements in maybe as a floor part of a waiver application. And this is an area that there's been a lot of research on, and I think the conclusions are pretty clear. What happens when you put a work requirement in place? Like, what is the goal, and what actually happens in those cases?
Well, I'll start. I would say, the stated goal is to try to make people work, right? And to get more people working in order to qualify for Medicaid. That is not what happens. There have been 2 states that have implemented work requirements in Medicaid. Arkansas early on, and it was thrown out by the court, and then Georgia, which has an ongoing work requirement. What happens is not that more people work, and there's no evidence that more people work. What happens is people get kicked off Medicaid because it becomes more complicated to just get and stay on Medicaid. You have to report your work or your exemption from the work requirement, often on a monthly basis. And we, essentially ration coverage through complexity, through that kind of reporting. And in Arkansas, it was, early on, it was even, it got even crazier. For example, the website where you would go to report your hours of work was only open from 9 to 5. So it was not open in the evening when people who were working might actually have time to report their work hours. So a significant number of people lost Medicaid during Arkansas's work requirement. Also, really important to remember, and Kody and Katie mentioned some of these statistics early on, that if you look at who is covered by Medicaid, you take out the elderly, you take out people who qualify based on a disability, who would not come under a work requirement. 92% of people are either working, going to school, providing care to a family member, or too ill or disabled to work. So the vast majority of people are already working. It's essentially a solution in search of a problem, which is not to say it wouldn't save a significant amount of money.
And it's interesting for those of us who remember before Clinton, it used to be that welfare and Medicaid were a package. And as part of the block granting, actually, of the TANF benefit, we disentangled the two. And I think that started a whole culture change around viewing Medicaid as really a core kind of benefit and right for poor working people that had not really existed before that change. So this would take us back in an interesting and not helpful way. Let's sit with the politics for a minute, and there are many other iterations of these cuts I think we could talk about, but I just want to remind us, ACA cuts were on the table how many times? Many, 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 many times. It was a very unpopular move, as it turned out, and they did not go through. Block grant of Medicaid has been proposed in the past. Again, never kind of went very far in the political process. I guess the 2 halves of the question I have now is what is going to be the nature of the opposition or the political reaction to these proposals, and what does that say for what is likely to happen?
I will restate my position in spite of Larry's tension, which is that, I think states have to balance their budget every year. It is a very tight fiscal environment in most states right now. And so they are going to be watching these sorts of cuts very, very closely. I mean, it's, as Katie said, it's number 1 or number 2 for every single state as far as the budget. And so, a slide in the FMAP, I think, leaves very few choices. And at least at the state level, there could be an illusion of like, oh, we have flexibility for innovation if we move to some sort of block grant or something that could kind of like paper over the cracks in some way. But when I think about, frankly, the constituencies in North Carolina, if they were to do anything to either shift the FMAP on, and we haven't talked about just the expansion, the 90-10 match, But, I can't remember, but I think a dozen states have a trigger law in place where that immediately kind of starts to unwind expansion. That's a lot of individuals that are constituents who vote, who I think could be, rallied to a cause pretty quickly if I think speed and these sorts of things would navigate. So, all that to say that, this is why I'm still a little bit suspicious that we'll actually see one of these particular things come true. I think we're more likely to see, congressional attempts to like rein in 1115 flexibilities because of the growth we've seen there, looking at state-directed payment programs because the constituencies there are a little bit more oblique. And so I think that's where some of the dollars and various things may come to play out, and not directly towards beneficiaries. But that's my kind of political read.
One way to think about these politics is kind of on two levels. One is kind of within Congress, and Republicans have, a very, very slim majority. I think it's a one vote margin currently in the House. So they basically need every Republican member of the House to vote for this budget reconciliation package. And there are kind of two opposing camps. I mean, there's a conservative camp, many of whom are in what's known as the House Freedom Caucus, who are insisting on spending cuts to help pay for tax cuts. They all want tax cuts. There's no question they all want the tax cuts. But these conservatives want spending cuts to help pay for those tax cuts. Partly because they just want to cut spending. Then there a group of somewhat more moderate House Republicans in swing districts, many of them in California and New York, who are nervous about these spending cuts, particularly spending cuts in Medicaid and SNAP food assistance and in the Affordable Care Act. So it's this kind of game of chicken between these two camps as to who's going to blink first. Then you get to the other level of politics, which is interest group politics. Certainly patient groups are going to be opposed to big Medicaid cuts, no matter what they are. They will probably not be the most influential voice. The most influential voice will be insurance companies, since over 60% of people enrolled in Medicaid are enrolled in a private insurance plan. Nursing homes, as we talked about, Medicaid is the primary payer of long-term care, hospitals, and physician groups. So, this coalition of interest groups, which we've seen come together in the past, like to fight ACA repeal and replace, will probably be the deciding factor. And remember, almost every member of Congress has a hospital in his or her district. So, and that hospital is often the biggest employer in that district. Many business leaders and community leaders are on the board of that hospital. So those hospitals can be very powerful voices in debates like this.
Yeah, I just can't underscore enough what Larry said about the interest groups and how sometimes the loudest voices, there are multiple consumer advocate, and we're also seeing labor coalitions nationally and in those swing districts, mostly in California and New York. They're already being targeted. And the most influential are going to be the folks focused on employment and all the industry groups. And so it's a very interesting dynamic, and some of the work that my foundation tries to do is pull those two interest groups together. There are folks who don't typically talk to each other. The people who are patient advocates are typically not on the same side of the table as, as a health insurance company, right? And so it's really hard to get them to walk around the table or meet in the middle and say, we actually all really care about this. I think, our industry partners and our patient advocates are all very sophisticated, and they understand what it's going to take to keep Medicaid front and center. I also think something that's interesting is the speed and the timeline at which this is happening. This is really, really fast. We are literally 1 month. We're not even a month in to this administration. And this is happening, right? Reconciliation bills are starting, the rules are out, they're starting to move. When you really think about those swing district folks who are scared, they really have about a year to make all of this happen. They've got to do the reconciliation bill or bills in this fiscal year, federal fiscal year, right? And then the midterm elections kick off at the end of 2025. So it all has to happen really, really fast. And it's very interesting to watch how, there have already been lots of action days and things like that on the Hill. Some of those moderate Republicans are already coming out and saying, yeah, this is a real big sticking issue. I do think, you know, I do think actions are going to speak louder than words on this one, right? So folks are, we're seeing lots of reports of moderate conservatives saying, oh goodness, can I really do this? And are they really going to vote? You know, are they really going to not vote on this kind of a package, but are they actually going to break with their party and vote? I think that is, it feels less likely than it has in the past. And I think they're under a lot of pressure. I'm not sure how this is going to play out, but it's going to play out real fast.
I think it was Kody mentioned the ACA expansion as another place that we could see a cut. Can you just quickly say what that would look like?
Sure. So, as part of the ACA, Medicaid expansion beneficiaries, the federal match, different than the formula, is at a 90-10 cost share. So the feds kick in 90%, states have to finance some way the other 10%. And many states have trigger laws in place that if that cost share were to ever change, then Medicaid expansion kind of, poof, turns into a pumpkin. And in that state, and so North Carolina is one such state, and so you could imagine essentially overnight, 600 and now 40,000 North Carolinians losing their health coverage if that were to go to 89, 90, 89, 11, right? And so, that is, moving that could, but again, this would also cost shift dollars onto the state, and some of those dynamics would play out.
All right, we have a question here from Sophia. What can we see from the Trump administration in terms of reducing healthcare costs for consumers other than just spending cuts? And this sort of a little bit reminds us of the MAHA agenda that the secretary has come in with. Like what do you see on the radar in terms of health cost reduction?
I'll do my sales pitch, which is, President Trump already laid the groundwork beautifully when he approved North Carolina's 1115 waiver, investing in the Healthy Opportunity pilots, right? Here we have investments in primary prevention that look like food, transportation, housing, and personal safety, and is lowering costs $85 per member per month. Like, if we want to over time lower the cost for health care, then we need people to be healthier. How those things work together. And Medicaid has historically not paid for the real 80%. The other 80%, as a smart friend of mine calls it, key drivers for health. And so my hope is that we'll lean harder into President Trump's big, beautiful pilot in North Carolina and see things like that. But I think that I think there are other innovations. I think there are things that could be done around streamlining administrative burden, right? 30 to 40% of healthcare costs are going to some sort of administrative layer, and so, having a harsher look at those sorts of things would be good too. And so there are opportunities. I'm hoping that we'll be able to start to parse things out and focus on them and not just go after blatant cuts.
Well, I like Kody's optimism. I think an important point embedded in Sophia's question is kind of when you think about healthcare costs, and every politician talks about lowering healthcare costs, right? I mean, it's just, they all do, but you really have to look carefully at when they're talking about healthcare costs, whose costs are they talking about? So, for example, in this budget reconciliation debate, that would reduce the federal government's healthcare costs a lot, but it would increase costs for states, it would increase costs for low-income people, it would increase costs for hospitals, and there's often that trade-off that lower government costs leads to higher costs for other people. So, really important to parse when a politician is talking about reducing healthcare costs, whose costs they're talking about.
Yeah, and I also looking at the details of Sophia's question, you said for consumers, and we're not seeing a lot of proposals that would reduce costs for consumers. There are other things, as Larry said, like the Medicare site neutrality proposal. That one would, put a burden on hospitals and also might make things better for primary care physicians who are seeing Medicare patients. They might get paid more. So it's really devil's in the details on these, on all of them.
And remembering that in general, Medicaid pays less than any other payer. And some states, in fact, in the Biden administration, one of the things they tied to waivers was increasing rates to be more comparable with Medicare. But likely that would go out the window and be reversed in any kind of cost-cutting scenario. All right, we have another question. If federal funding for Medicaid ends up decreasing due to future bills from Congress, do you expect states to make up for the funding gap? And the person goes on to say, I understand this may vary state to state, but in general, would states want to try to kind of hold harmless the funding?
I don't think a lot of states can.
Yeah.
Katie, what's the whole total California budget?
Over 300 billion, but general funds probably around 200 billion. And
Yeah.
we're talking 10% of that, right? 20 billion. I don't know.
You got pennies on the dollar in the savings account. No, it's the wherewithal for tax increases and everything else. So no, I see no way in which the Medicaid program is cut where people do not feel that pain directly.
Yeah, I tend to agree. And I mean, take this proposal Kody was talking about, eliminating that enhanced match for the Affordable Care Act Medicaid expansion. If that were reduced to the state's regular match, we put out an analysis last week, that would decrease federal spending by over $600 billion over 10 years. So that would be the amount of money states would have to make up in order to keep the expansion, which is just an enormous amount of money. I mean, in California alone, it would be $13 billion over 10 years.
Yeah, you can't absorb that kind of cut. And also, and then you get into really, as Claudia said, you get into really difficult state political decisions. California has a very liberal governor who has also said no tax increases because he has other aspirations beyond his tenure in the California's governor's office, right? So he doesn't want to increase taxes. And he has other priorities as well. He also is committed to continuing to cover undocumented immigrants in Medi-Cal. That is worth literally billions of dollars in our state budget. Could be really easy to cut. And also it's a really, really important tenet of his governorship. So we come down to really difficult decisions real quick.
One other question from a student. Given that the U.S. doesn't have universal health care and there's a lot of private interest in health care, how strong is the argument that in the long term there will be more costs than benefits to the economy associated with more health debt, loss of jobs in the health industry without Medicaid? So in other words, what's the economic impact for all of us if we take these cuts that may not affect us directly?
I mean, I think it's interesting. So this is not an endorsement of any analysis, but something that has caught the imagination of policymakers in North Carolina over the last few weeks was a list Forbes put out about healthcare costs relative to their consumers, of which North Carolina had the most expensive cost for healthcare for consumers in the country. And the talking point has been, and the United States has the most expensive healthcare costs for consumers in the world. So North Carolina is leading the world in the wrong way. And in California, and I think Massachusetts had some of the lowest healthcare costs for consumers in the country. And it's been so fascinating to me, the number of state legislators that have called me to be like, Kody, how do we crack the code on this? What's going on? And it was just like, first off, it's for consumers. Second off, California, as Katie pointed out earlier, expanded Medicaid midnight, January 1st, 2014. I mean, getting people access to health insurance lowers their cost immediately, and then also helps lower costs for the system as people have access to secondary and tertiary prevention strategies. I don't want to suggest that there's no opportunity for efficiency, there's no opportunity to make something better. But, a lot of the cuts that we are talking about would certainly increase costs, as Larry beautifully pointed out, to someone else in the near term and to all of us in the long term, period. And yet, from a values perspective, our country loves to spend more money for various decisions. Like this is not like there's no efficiency. There's no 4% of the federal budget is the federal workforce, and so all these cuts to workforce is not saving money either, right? So like efficiency is often a veil that covers many other things.
All right, let's take a final question. And this is, how would these cuts impact dual covered individuals, meaning those with Medicaid as well as Medicare? Would these individuals see significant reductions in benefits, or do you expect Medicare to expand some benefits to make up for the changes?
I do not see Medicare expanding benefits in the near term. Medicare has a lot of gaps. The cost sharing, the deductibles for Medicare can be quite high. The premiums can be quite high. Claudia, as you said, Medicare doesn't cover long-term care. Medicaid fills in that gap. So Medicaid for people who are low income and on Medicare because they're a senior, because they qualify based on disability, Medicaid fills in those gaps. These dual covered individuals are are the people with some of the highest needs on both Medicare and Medicaid. They're people in nursing homes, or people getting other kinds of long-term care. Frankly, they're in many ways the most vulnerable if you imagine something like a per capita cap. So, I would expect to hear a lot about these people, these individuals over the coming months, just because of how vulnerable they are.
Maybe I'll just say, first of all, my huge thank you to all three of you for joining. This was an amazing conversation, and I really appreciated how each of your perspectives and experience played into informing a really 360 view of what this could look like.